Welcome to Bench to Bedside, a weekly series of live conversations about recent advances in cancer, from the research bench to treatment at the patient's bedside. And now, your host and the director of the University of Kansas Cancer Center, Dr. Roy Jensen.
An immunotherapy advancement called Carty cell therapy is one of today's most exciting developing cancer treatments. In its early development, Carty has been used to treat deadly blood cancers like leukemia, lymphoma, and multiple myeloma with stunning results. Among patients with these cancers who once faced a dire prognosis of just months or weeks to live after traditional treatments failed them, we are today seeing complete remission rates of 50 to 90%. With these revolutionary early results, oncology leaders now ask, who else can we help? I'm Dr. Roy Jensen, Director of the University of Kansas Cancer Center, and with me is Dr. Joseph McGuirk, Division Director of Hematologic Malignancies of Blood and Marrow Transplant and Cellular Therapies. Now, today we're going to have a special segment, and the empty chair that you see is for a special guest we're going to bring on at the end of today's show to talk about the novel coronavirus and advice for cancer patients. You'll certainly want to stay tuned for that segment. But first, we're going to discuss Carty cell therapy and its results and really dramatic potential to be used in cancer treatment for not only hematologic malignancies, but also solid tumors. I want to thank you, Dr. McGuirk, for joining us for today's episode of Bench to Bedside. Just to start off, could you give us kind of a simple definition of Carty cell therapy and describe how it works?
You bet. Thank you, Dr. Jensen. Thank you for having me here this morning. So it's important before we get to CAR T cells to talk about what T cells in our immune system do in the first place. T cells are an important arm of our immune system, and their job is to look for invaders, infection, for example, attack and destroy. But they actually do the same thing against cells that are misbehaving in our body, not just infected cells. So if cells are misshapen, behaving abnormally, T cells will recognize that, attach to them, and destroy them. And so they survey for cancer cells. These abnormal cells, as you're well aware, can evolve into a frank cancer. And we're confronted, likely tens of thousands of times throughout our life's journey with these abnormal cells. Yet, a significant percentage of us never develop cancers, but some of us do. And so how is that? How can we contend with these cells successfully? And sometimes it fails us. And it can be a two-pronged issue. One is the cancer itself can manipulate the immune system and hide out from the immune system. And another, the immune system is not working adequately. And when those two things combine together, cancers can propagate. So with a better understanding of how these T cells control cancer in the best of circumstances, these cells have been isolated from patients with cancer, taken out of their bloodstream to the laboratory, and genetically re-engineered to again recognize the cancer cells and do their job. They're expanded in the laboratory and infused intravenously into patients. They sweep around the body, recognize cancer cells, attach them, punch holes in them, and tear up their innards, if you will, their chromosomes. And so this has been an extraordinary development in cancer therapeutics, as you mentioned, seeing remarkable results in patients who had nowhere else to turn and had their survival numbered in weeks to months, now being put into complete remission, and many patients surviving years and likely cured of their disease. Remarkable development.
Mm-hmm. So could you tell us a little bit about some of the early studies in Carty and what the results from those studies have been?
Yes, absolutely. So the first studies were actually directed at blood cancers, as you mentioned earlier. In particular, a type of acute leukemia called acute lymphoblastic leukemia, and the most common form of non-Hodgkin's lymphoma in adults called diffuse large cell lymphoma. And in these cancers, there are specific molecules on the surface that allow them to be targeted successfully, those molecules not present on normal healthy tissues, without causing collateral damage to normal healthy tissues. Could be directed right at the cancer cells in particular. As you're well aware, University of Kansas Cancer Center has been on the forefront of this. So we were the first center in the world community to enroll on the first multi-center, multinational trial of these CAR T cell therapies several years ago in diffuse large cell lymphoma. And we saw complete remission rates that would have been expected with conventional therapy to be 7% to be 54%, a stunning improvement. The majority of those patients going into complete remission, remaining in complete remission with beyond 2 years of follow-up. That led to the Food and Drug Administration approval, first approval of these CAR T-cell therapies for diffuse large cell lymphoma and for acute lymphoblastic leukemia both. So those really critically stunning results. More recently, another form of non-Hodgkin's lymphoma, mantle cell lymphoma, we've seen almost a 90% complete remission rate, the majority of those patients staying in complete remission beyond 2 years, and then multiple myeloma also seeing complete remission rates up to 100%, and a significant percentage of those patients also staying in complete remissions. There's a lot of work to do. Some patients don't go into remission. Some patients relapse despite having initial responses. But nonetheless, these are stunning results that are catapulting us into a new era of cancer therapeutics.
Well, those results truly are spectacular. If you're just joining us, we're here today with Dr. Joseph McGuirk, leader of our blood and marrow transplant and cellular therapeutics program, and we're discussing CAR T-cell therapy and its early results. Cameron Poindexter is here in the studio to take your questions. And remember to share this link with people you think might benefit from our discussion. Use the hashtag #BenchToBedside. So let's move on now and take a look at how these early outcomes are really sparking questions around what other opportunities we may have for CAR T therapy in cancer. So Dr. McGuirk, if you could tell us a little bit about how we hope to move CAR T therapy into the solid tumor realm.
Yes, absolutely. Solid tumors, in contrast to the blood cancers, which are relatively rare cancers in the big scheme of things, solid tumors are the heavy hitters. Breast cancer, colon cancer, lung cancer, prostate cancer, for example. There are many hundreds of thousands more patients with those cancers than the blood cancers I described earlier. And solid tumors present some unique challenges. These cancers are, as we know well, they're smart, and they have many survival strategies to circumvent the immune system. One survival strategy is to surround themselves with a bunch of supportive cells, sentries, if you will, that will prevent the immune cells from getting into the tumor and being able to make their way to the tumor cell and kill the tumor cell in the way that, that they do with blood cancers. So strategies have been unfolding to identify molecules on the surface of solid tumor cancer cells that are minimally or not at all expressed on other tissues. And that's been a particular challenge in the field, yet that is happening, it's unfolding. In addition, these CAR T cells are being armed with molecules that basically chew away at the tumor, allowing the T cell to make its way into the deep innards of the tumor so that it can attack the cancer cell and kill the cancer cell. So it's really a quite remarkable time. A number of investigations in our own center that are unfolding quickly in solid tumors are Dr. Parik's study in prostate cancer. Prostate cancer has a molecule that's unique to the prostate tissue in prostate cancer, and can be targeted with specifically homing those T cells to the prostate cancer without causing collateral damage to normal tissues in the intestines or the lungs or the brain, etc. A critically important point. And so we have great hope for Dr. Parik's study, which will soon be available in enrolling patients at our center. Dr. Baranda has a study that looks at a molecule that's somewhat unique to cancer cells, somewhat broadly, across tumors, breast cancer, for example, gastrointestinal cancers, lung cancer, and where patients with any of those diseases may present with this molecule. It's an early phase study. There's a lot that needs to be worked out, but we're very hopeful that that study, too, is going to allow us to target these cancer cells specifically without causing untoward collateral damage and be effective in eradicating these cancers. And there are a number of other studies. We currently at University of Kansas Cancer Center have 19 active cellular therapy trials using these CAR T cells and other even more novel constructs that are being developed. And we have 20 that are in the pipeline in various committees for review.
So Cameron, it looks like we have a question. Could we hear what that is?
Yes, the first question is, can CAR T-cell therapy treat sarcoma?
That's a very good question. Sarcoma is a It has also some unique molecules that can be targeted that are minimally expressed on other tissues. And Dr. Ben Powers, in conjunction with Dr. Branda and our center, are in the process of opening a study specifically looking at sarcoma. There have been promising results in the laboratory and in early clinical phase trials, and we will soon have that study open and available. Now, it's a very narrowly defined population of patients with a specific type of sarcoma, but yes, we are hopeful that we'll make some inroads into sarcoma with these CAR T-cell therapies.
So, Dr. McGuirk, could you tell us about how you and your team have really moved into this space in such a rapid and aggressive fashion? I mean, it's stunning to me how we've gone to almost 40 trials with cellular therapy in a relatively short period of time. How did that happen?
Absolutely. Well, that's your doing, actually, because you built a cancer center for us with a remarkable infrastructure. That's a yes sir, yes ma'am, right away attitude for our patients and their families in getting the job done. And so we've leveraged that infrastructure of our clinical trials office. We also leverage the infrastructure of our stem cell transplant program, which is one of the largest in the nation and has been on the forefront, as you know, as have other programs in our cancer center in clinical trials development. So as this field started unfolding, we already had a large clinical trial infrastructure in place, and we had a large transplant program to handle these cells in place that allowed us to do that. We're accredited by a cell therapy accreditation body called FACT, and we were one of the first programs in the nation to be accredited for what's called immune effector cell therapy, which is a mouthful, but it says this is a safe, frontline, state-of-the-art program and an institution that can allow for the safe application of these investigational cellular therapeutics. And so we published in 2017 an important article from our institution describing to other centers around the country how we leveraged our cancer center infrastructure, our stem cell transplant program infrastructure, brought those things together, and our clinical trial experience. And that became the pharmaceutical industry and other academic centers became well aware in short order of our accomplishments at KU, and centers came to us, pharmaceutical companies came to us, as did other academic centers, for participation in these important early clinical studies. So that allowed us to be on the front end of this brave new world of cancer therapeutics, extremely promising world. So we've been fortunate, and it's our determination to continue to be right out there on the cutting edge for the benefit of our patients, their families, and our community.
So it looks like we have another question. Before we get to that, I always want to acknowledge the role that the JCERT program has played in providing the infrastructure for our clinical research program. And right now, as you know, we receive right around $6 million a year to support that infrastructure, and that's absolutely critical to be able to having us, be competitive for these trials and move this research forward. So, Cameron, what's our next question?
The second question is, could you talk about the challenges of managing the logistics of CAR T treatment for potential patients who live far from treatment centers?
This is really important, a very thoughtful question. So because we were on the front end of this, we had patients coming from other nations to our cancer center for therapy, patients from Australia, from Western Europe, from Newfoundland, and from around the nation. As a matter of fact, one of the large cancer centers in our country was sending patients to us when they didn't have their trial open. We had to accommodate these patients, so lots of logistics involved with that. And so, as I mentioned, the infrastructure of our transplant program, which was already in place to accommodate patients coming from afar. We have patients out at the Colorado border 10 hours away who routinely come to our center for care. There was some experience. The American Cancer Society, Hope Lodge, obviously, was important to leverage to support these patients. But one of the really important take-homes when we talk to other centers about setting up CAR T-cell therapy clinical trials and the commercial constructs that are currently FDA approved is you have to do things in parallel. You can't do them sequentially. These patients are sick, they have aggressive tumors, they'll succumb if you take too long in getting things arranged. So as soon as we get that phone call from a referring physician or from a patient in their family, as I mentioned earlier, it's yes sir, yes ma'am right away. Our medical records people extract medical records from that office in 24 hours. We will see that patient no matter where they reside in this nation in 24 hours, and we tell them so. We get their tissue blocks so our pathologist can take a look at them. Social worker starts working on how we're going to get them here, how we're going to lodge them when we're here, what will transportation look like. Our financial folks start working on clinical trial eligibility. So you have to do these things in parallel. So we have a team called the Car Hub team. We get the phone call, and this happens on a daily basis in our institution, and that immediately starts the army of multidisciplinary team in getting these patients taken care of. It's really quite remarkable to watch, and I think it's what patients and their families want to think about healthcare when they think about a coordinated multidisciplinary effort and many eyes on them and their situation.
So do we have another question?
Yes,
Jim?
we have
Okay.
3 questions. The first question is, Dr. McGuirk, what are you most excited about in the field of immunotherapy?
Everything. I think that it's a really stunning time. It's a gee whiz science time from my perspective. I've been an oncologist now for 30 years. I've always been excited and optimistic about the future for our patients and their families and for our field, but never as much so as I am now. And you would think that would wane with time, and it's actually increased with time because our understanding of the biology of cancers, our ability to leverage that knowledge, the biology of the immune system as I described, and our ability to leverage that and combine those things. So in the future, it won't just be CAR T cells or other constructs like that that are cellular therapeutics. It'll be combining those things with molecules that interfere with the proteins that drive these cancers internally, molecules that block the ability of the cancer cell, molecules called checkpoint inhibitors that block the ability of the cancer cell to manipulate the immune system. Combinations of these therapies that are going to replace many of the old cancer therapeutics, chemotherapy that I've used for years that were nonspecific and not precisely directed at the cancer and cause a lot of collateral damage and illness in patients. So this is an extraordinary time. Immunotherapy will be an absolute pillar of stability going forward in the management of patients with cancers.
So the second question is, can CAR T-cell therapy treat stage 4 lung cancer?
As I mentioned earlier, Dr. Baranda in our cancer center will be opening a study looking at CAR T-cell therapy in advanced stage 3 and 4 lung cancer. That study I expect will be open here in the next couple of months. There will be very specific criteria for entry into that clinical trial that Dr. Baranda and our center will be able to address what those criteria are. But the answer is lung cancer is absolutely a target of a number of studies, including in our own cancer center for cellular therapeutics.
The third question is, what can individuals do to help educate their communities about CAR T and the current opportunities at the University of Kansas Cancer Center?
This too is a really thoughtful, very important question. One of the disappointments in the field to date has been that we can cure patients with diffuse large cell lymphoma and acute lymphoblastic leukemia. We know that confidently. Not everyone, but we certainly can. And unfortunately, in the first year of CAR T-cell therapy for the most common form of non-Hodgkin's lymphoma, as I mentioned, diffuse large cell lymphoma, only 8% of eligible patients in the United States were able to get to a center like ours for CAR T-cell therapy. That improved last year. It was about 15%. But that means there are thousands of lives out there who are not getting the word. And so our outreach, we're an academic center. We blanket the state of Kansas, parts of Missouri, Nebraska, Oklahoma, and Arkansas to educate our referring physician colleagues and their teams. But we also have to educate the public about what therapies are available to them. So it's really important, and we have a lot of work to do because, again, 15% of patients who are eligible for a potentially curative therapy actually knowing about it or accessing it is unacceptable.
So
yes, we have
looks like
another
question. Yeah.
So can you address the reimbursement issues related to CAR T-cell therapy?
This too is a critically important issue. A lot of great questions coming from our audience. These are costly therapies, without question. It's been a challenge to our system in the United States. The American Association of Cancer Institutes, the National Marrow Donor Program, many healthcare economists have helped us work with Congress to allow these to be funded therapies. But we also have to figure out strategies to bring the cost down. Now, today, the CAR T-cell therapy for the appropriate indications, the FDA-approved indications, has come a long way since we first started, and we were struggling to get these cancer therapies approved for our patients with the great potential that they had to improve their lives. We've made a lot of headway with Congress and with the private insurance industry, with government payers, to make sure that these therapies get paid for, and clinical trials are increasingly approved. But we have other constructs. As I mentioned, we anticipate in the next year we're going to have 2 approvals for multiple myeloma. We're going to have an approval by the FDA, hopefully. One never knows, but we're hopeful we'll see an approval for mantle cell lymphoma. And then as we move into solid tumors, a lot more to come. So this is an area whereby we have to have a multi-pronged approach as well. We have to work with the pharmaceutical industry on strategies to bring those costs down, and many strategies to affect that are underway. We also have to continue to have an open line of communication with our House and Senate colleagues, representatives, and senators to make sure that we stay out in front of this. And then we have to work with the pharmaceutical industry to make these therapies more cost-effective, more readily available in a timely manner. Otherwise, as we move into these heavy hitter cancers, we're really going to be challenged if the therapies continue to cost $500,000 per individual.
So you alluded to this earlier. What is new on the horizon in terms of the CAR T constructs or the approaches that CAR T is going to take? What excites you about some of these newer therapies that are coming down the pike?
A number of things, Dr. Jensen, and I could go on for a long time, but very briefly, some of the most promising strategies are asking the question of, should we be using the patient's T cells? After all, these T cells have failed the patient, and even after we genetically re-engineer them, we can get 50% of the patients into remission, but what about the other 50% of patients? So how can we do this better, and should we use more fit T cells? And so strategies to use normal healthy donors, young normal healthy donors whose T cells have never seen cancer, have never seen chemotherapy and been affected by the chemotherapy. So what we call third-party off-the-shelf cells. If we can employ that strategy through genetic engineering, instead of waiting the weeks that it takes to make a patient's own cells, genetically engineer their own cells, and the patient could succumb, progress, and no longer be a candidate and die from their disease. We could have cells available on the shelf somewhere in a pharmaceutical company, call up for them, and like a drug, have them sent the next day. It presents particular barriers, but with new gene editing strategies, a strategy called CRISPR-Cas9, we can take out the molecules that would cause those cells to be rejected or for those cells to attack the patient's own tissues. And this, we think, will potentially greatly drive down cost, make it much more readily available, and potentially give us T cells that are healthier and going to do a better job of killing the cancer cells. So that's just one example. There are a number of other strategies using maybe T cells. There's another population of cells, as you well know, called natural killer cells. And some recent publications telling us that if we arm these natural killer cells with the constructs that can see the cancer, they too can kill very effectively. So finding the right type of cells, using third-party cells from normal, healthy people, and then arming these cells with a molecule I mentioned earlier, Dr. Parik's study that he'll be opening in prostate cancer. In that study, he has a molecule called TGF-beta, and that helps the cells dig their way, bore their way into the cancers and kill the cancer cells. And so they're what we call armored T cells. They're CAR, they can recognize the cancer, and they're armored with molecules to knock their way into the tumor. Those strategies are just the tip of the iceberg of an extraordinary array of therapies that people are pursuing aggressively around the globe, including at our own cancer center, to figure out how to move that up 50 to 75 to 90 to 100% and minimize the collateral damage. These are not non-toxic therapies today. They can cause something called cytokine release syndrome, which is like the flu times 10. They can cause neurological symptoms in patients. Patients can become quite ill. So a number of centers, again, including our own cancer center, are looking at strategies to mitigate the toxicities without compromising the effectiveness of these cells in killing cancer cells. And a lot of promising stories are unfolding there, too.
That's incredibly exciting. So at this point in the program, we want to invite Dr. Dana Hawkinson, Medical Director of Infection Control. Dana, come on in.
Hi.
At the University of Kansas Health System to join us to talk about the novel coronavirus with specific regard to cancer patients. Dr. Hawkinson, thanks so much for joining us this morning.
Hi, thank you.
Could you first tell us about kind of the current state of the virus, not only here locally, but nationally perhaps? What are the risks? What do we know? What do we don't know? And how are things changing?
Yeah, as a quick overview of novel coronavirus, or SARS-CoV-2, obviously most people know this was a virus, an infection that was discovered originally in December 2019 in China. There were multiple infections. There continued to be widespread infection, and now it's kind of reached around the globe. At this point in time, there is not a lot of or any local spread. In the United States, there are some communities that have had person-to-person and community spread, but this number and these infections are changing day by day. So a lot of what we're saying is at this point in time or at the current state. This virus is similar to the SARS virus, which was originally discovered in 2002. It has about 70 to 80% homology with that virus. That means it's really similar. In most people, in 80% of people, it causes very mild illness in which you don't need hospitalization. It doesn't really seem to affect children or patients under the age of 19. In fact, I think it's about 2% of cases or less from the published reports. But in general, if we're talking about other patient populations, such as anybody with underlying comorbid illnesses, such as heart failure, diabetes, underlying lung disease, and of course any neoplastic or oncologic disease, certainly they can develop and progress to severe disease in a higher probability than other patients who don't have those underlying diseases.
So Dr. McGuirk, in regards to cancer patients, which ones would you say are at greatest risk for major complications for COVID-19? I suspect that many of the patients that you care for fall into that category.
Yes, very much so. Many of our therapies compromise the immune system, and particularly in the blood cancers, where it's the immune system itself and parts of it that are cancerous, and so we suppress the immune system on purpose, and that sets our patients up for risk for infections, including this organism as well. Many of our patients are of advanced age, and that in and of itself appears to be a risk factor for the acquisition and becoming quite ill in a threatening way with this virus. And patients who have received in general, beyond those particular populations, bone marrow transplant, blood cancer patients, but even solid tumor patients who are actively receiving or relatively recently have received chemotherapy, those are vulnerable populations of patients in particular with this virus.
Mm-hmm. So, Dr. Hawkinson, what is your general advice for cancer patients in regards to exposure to this virus and how to prevent that?
Yeah. First of all, I want to say I echo everything that Dr. McGuirk has said. It's all absolutely true. As far as protecting yourself, again, individual vigilance has been most important, and that includes appropriate hand washing. Certainly in populations that are older or have the underlying cancer diagnoses or on chemotherapy, trying to social distancing, keeping yourself not necessarily isolated or quarantined, but trying to avoid areas where there's mass groups or mass gatherings. You know, this includes anything from possible sports events to bus stations to airports, you know, sometimes even grocery shopping or churches. It's important to understand those risks And in doing so, also because we are touching surfaces all the time, door handles, railings, and this disease is really caused by droplets, but also fomites, which are inanimate objects, such as high-touch surfaces. We touch those surfaces, and then we're touching our eyes, our nose, our mouth. That is the main ways that we are able to contract this disease. So staying vigilant in hand hygiene, trying to avoid putting your hands in your eyes, nose, mouth, social distancing as much as possible. Those are really the main ways that we can stay healthy, especially if we do have underlying malignancy or chemotherapy or otherwise immunocompromised state. And again, at this point in time locally, it doesn't seem like there's community spread, but things can change rapidly in the next week, in the next 2 weeks, 3 weeks. And so it's important to stay vigilant on the news, keeping up with the accurate websites such as the CDC and the Kansas Department of Health and local health departments for their news and advisories on travel and other things to do to protect yourself.
So that advice sounds, very similar to what we're giving to the general public. I'm sure that one of the specific questions that cancer patient has is around their appointments and coming in to see the physicians. Are there any is there any advice around that situation that either one of you have? Say, in the first case where someone is just concerned about being exposed to the virus, in the second case where they may be exhibiting symptoms that cause them to be concerned.
Yeah, I'll just start by saying, as an individual, you are probably more at risk of complications or problems by not seeing your physician. So if you think there are issues, absolutely call the clinic, absolutely call the physician, and try to get some guidance at that point. Because there are other things out there as well. And again, locally, there's not a lot of community spread. The disease rate is not high for COVID-19. But there are certainly other things that are still important and can cause severe illness. Influenza activity around here is still very high. We diagnose multiple cases of influenza every day here at the health system, both in the inpatient setting and outpatient setting. So individually, I would say continue to be vigilant, talk with your provider, get good guidance, and by all means, if it's safe and you've talked with your provider, please come into your clinic visit, because missing a clinic visit could be even worse. And I'll let Dr. McGuirk speak on kind of the global issues with the clinics.
I completely concur. That's exactly right, and that is the straightforward, sensible advice to contact the treating team, the healthcare team. There are, as Dr. Hawkinson just mentioned, the majority of our patients who have respiratory viral symptoms, and it's common at this time of year. We've seen these patients every day in our cancer center and our bone marrow transplant clinic, are influenza, respiratory syncytial virus, parainfluenza. And some of these viruses can be very aggressive in our population of patients, and we have treatments, effective treatments for some of them, not all of them. And so it's always critically important that we know about that and we can guide our patients in terms of coming in, taking special precautions, for example, in coming to clinic to minimize exposure to others, regardless of what type of virus it is, and then isolating those patients as soon as they come in so that we can investigate what's going on with them.
Okay. Cameron, it looks like we have a question from our audience.
Yes, we do. The audience wants to know, can you have the flu and coronavirus at the same time?
Dr. Hawkinson?
So initial reports and anecdotal reports and the data would suggest that with other infections, other viral infections, you certainly can have co-infections, and sometimes those percentages of people that have co-infections can be fairly high. With COVID-19 and other infections such as influenza, it doesn't seem like there is a high rate of co-infection. So at this point in time, what we are telling patients is if you have tested positive for influenza, you're positive for influenza. There's, at this point in time, no need to further test for COVID-19.
Mm-hmm. So another question I think that we get pretty often is, what about traveling or attending sporting events or concerts or large crowds or things like that? What approach should cancer patients in particular take in regards to those types of events?
We're currently, and be interested to hear what Dr. Hawkinson says about this approach, we're currently being very prudent and very conservative in our cancer center in recommending that our patients, and particularly those who are most vulnerable, patients in active treatment or relatively recent treatment, all of our patients with blood cancers, that they not travel unless it's absolutely essential, and then that we help coordinate that effort for them, that they stay away from large crowds of patients, that they even consider during this particular time avoiding church, going to the grocery store in the off hours. But as Dr. Hawkinson pointed out earlier, when they go to that grocery store, being mindful of what they're touching, keeping their hands away from their face, taking Purell, for example, with them and washing their hands frequently. So some practical measures. With regard to even our staff, our physicians, as you know, Dr. Jensen, we've canceled and rescheduled a number of really important meetings that people worked all year long, because if our healthcare providers become ill, first and foremost, they won't be able to care for the patients that we need to be caring for. But secondly, they may have an asymptomatic phase and they can spread that virus potentially. So I think we're pulling out all the stops in our institution to mitigate a rapid expansion of this virus in our community. And part of that traveling, self-imposed traveling restrictions, not just on our patients and their families, but also on our faculty, and not having large groups of people to get together. This has been a very important issue over the last couple of weeks.
Yeah. So, Dr. Hawkinson, could you talk a little bit about the steps that have been taken at our institution to really ensure that any patient that would come here to be treated for coronavirus is not only has the infrastructure and the support that they need, but also what we've done to protect our staff and our other patients from becoming infected with the virus?
Yeah, we have had a multidisciplinary approach at the health system for many years now to dealing with emerging infectious diseases. So we have had multiple service lines available to help to formulate plans. This includes emergency management, the emergency department, the supply chain, making sure we have enough supplies and resources to be used. We have protocols for bringing patients in a controlled manner, getting the patients to the correct isolation or precaution rooms, and then thereby keeping our other patients safe as well as our healthcare providers. And so we take that with utmost importance, and we feel that we have worked on these processes and procedures for the past few years. We tried to smooth them out as much as possible. We've been hoping for the best and preparing for the worst, and we continue to streamline these processes. And this includes not only the hospital, but also the clinics, including Westwood Clinic as well.
So, sounds like we have a question from our audience.
Yes, the audience wants to know, what should you do if you think you might be infected?
Dr. Hawkinson?
What should we do if we think that you might be infected with COVID-19? The first thing to do is probably call your primary care provider or your treating team, especially if you are one of the cancer center patients. Call the treating team first. Get some information from them. At this point in time, the testing is certainly done through the state. And so any testing would be performed through the state, and we would get the testing performed should you need it. There are still screening criteria which we need to abide by, but I think the first thing to do is call the treating team, get information from them, and then they are able to relay it to the infection prevention team, and we will determine should we be testing for COVID-19 or is it another illness. And as Dr. McGuirk pointed out, there are certainly other respiratory viruses still going on. There are still other illnesses out there. And so I think getting that information from your treating team, from your treating physician, is probably the first step.
Okay. Looks like we have an additional question.
Yes, where should you go for more information about the coronavirus?
Well, the best places to go are accurate and informative websites. The best is probably CDC, so cdc.gov. Another important one is probably your state health department, whether it's Kansas Department of Health and Environment or Missouri state health department. I would say start there because we all know that there's plenty of information out there on the internet, but those are probably the most reliable resources for COVID-19.
So I think one of the most encouraging things that I've heard about the COVID pandemic is that there's been one report out of China, one report out of Seattle, that infection control protocols within healthcare systems work against this virus. Mm-hmm. And the two reports that I'm referring to, and while this is early, there's been no transmission to healthcare workers that have taken the appropriate precautions, either in China or in Seattle. And so I think that is, that's an extraordinarily positive development.
Yep. It certainly reinforces the fact that simple measures help constrain this virus. Simple measures such as hand washing, proper equipment, the gloves, the gowns, the droplet precautions. Again, it's important for us to keep our healthcare workers safe so they can treat ill patients and also keep other patients safe. And so I would agree 100% with what you said.
So it sounds like we have another question.
Yes. The audience wants to know, what are your considerations for the rural community regarding coronavirus?
The considerations for the rural community in COVID-19? Well, again, I think at this point, there is not a large or any community spread around this area. The rural community still seems to be safe. Obviously, being rural, you are not interacting with many other people in general. So I think it's just a matter of keeping an eye on your own health and continuing to monitor for any community spread or activity of the virus at this point in time, and just monitoring.
Okay. Yeah. What about the prospects for a vaccine against COVID?
Yeah. I know people are working on it. Labs are working on vaccination as well as therapeutics. There are no treatments for this virus. At this point in time, it's probably at least 1 to 2 years away, I would suspect, for a vaccine. For other therapies, those are currently in trials, either anecdotally or through government trials as well. But at this point in time, there's really nothing else to use other than supportive care.
Mm-hmm. So I want to thank both you, Dr. McGuirk and Dr. Hawkinson, for coming on today. And that's it for this episode. To learn more about CAR T cell therapy, please visit kucancercenter.org/CAR-T. Join us next time for Bench to Bedside. Thanks for watching.